The natural history of kneecap dislocations suggests that the group at highest risk for instability is the teenage female. Predictors of recurrent instability are a prior dislocation. A first-time dislocation only has about a 17% incidence of recurrent dislocation. And based on the Finithin article in 2004, MPFL, retinacular, and VMO injuries on MRI have a lower risk of subsequent dislocation. A study out of the Scandinavian literature compared non-operative and operative reports. This is the only level 1 study comparing surgical and non-surgical management. I was wondering, would it be possible for me to sit down with this lecture? I'm feeling a little woozy. Okay. Could we just move the mouse over there and I just sit down?
Maybe I can change for you.
I think I might be able to do this. Yeah. Thank you. So the natural history shows, and this level 1 study showed that operative treatment had good or excellent results in about 67% of the patients, and non-operative treatment had good or excellent results in 87% of the patients, indicating that after a first-time dislocation, it is better not to do surgery than to do surgery. Now, there are exceptions to this. One exception is the presence of a loose body. So if there's a piece of bone or cartilage that's significant inside the joint, it is going to limit the ability of the patient to do rehabilitation. And anything that slows down the rehabilitation needs to be eliminated. And that would be removing the loose body, taking out osteochondral fractures or major chondral injury, or if there's a persistent lateral subluxation of the patella, it would be best to address it at that time. The diagnosis of patellofemoral instability is basically one of the history. Now, there are a number of different physical examination findings that you can look for. The tenderness, the presence of an effusion, the range of motion, whether there is compression or pain during tracking, a J sign in which the kneecap pops over into the groove as it goes from full extension into flexion, and the amount of mobility and the Q angle. Unfortunately, none of those are very consistent. The sensitivity of these clinical tests is less than 50%. And I think one of the most important things to get is a good, careful history. Hyperlaxity is another confounding variable, and there is a score called the Carter-Wilkinson score in which 5 different parameters are measured. Hyperextension of the elbow, hyperextension of the knee, the being able to put your palms flat on the ground with the legs straight, being able to bring your small finger back to a 90-degree angle, being able to put your thumb on your forearm. 4 out of the 5 of those being positive is positive for hyperlaxity. And then age makes has an important impact, because I usually don't see women in their 20s and 30s starting to have kneecap instability without trauma. So how do we assess this? Well, we assess the patient with radiographs. A true lateral is the most important study that you can get. Merchant's view, taken at about 30 degrees, gives the underlying contour of the patella, and that's also helpful. But on this true lateral, you can measure the patellar height, you can look for trochlear dysplasia and its severity, you can look for patella tilt, and you can look for the presence of arthritis and spurring. There are different studies to measure patella height: Insall-Salvati, Blackburn-Peel, Canton-Descamps. And they have different measurements of the length of the patella versus where the patella tendon goes to on the tibia. Now, other measurements you can get from the lateral view are the crossing sign And then with MRI or CT scan, you can get a TTTG. That stands for trochlear groove tibial tuberosity difference. So let me tell you about the patellar height. Insol salvati is what I typically use, and you measure the length of the patella and the length of the patella tendon. And if the ratio is greater than 1.2, you have patella alta, which significantly affects the instability because the higher the patella rides up the femur, the more likely it is to be outside of the groove of the trochlea and be more unstable. So an Insol salvati ratio of greater than 1.2 is the diagnosis of patella baja. Blackburn Peel is a little bit more complicated. The Canton Descamps is essentially the same as the Insol salvati, but it's just measured a little bit differently. Now, the crossing sign, which was described by Dr. DeJure, who's also at this meeting, measures the trochlear floor. Now, the black line that is on this sign on this picture is the Blumenstadt line. And the Blumenstadt line is the intercondylar notch. Well, where the intercondylar notch then sweeps up to the top is the floor of the trochlea. And where this crosses the lateral femoral condyle, that point is where the trochlea is flat. Now, the further distal that is, that means the flatter your trochlea is and the more trochlear dysplasia you have. Dr. DeJure and his father came up with 4 different classifications, a type A, B, C, and D. C and D are the most important ones, and as you can see on the correlation between the x-rays, you get this double contour with a very flat trochlea, and that can lead to patella instability. The TTTG is one of the measurements that seems to be very popular in the United States, and it's the distance between the tibial tubercle and the trochlear groove. This can be measured on CT scan or on MRI. The take-home number is greater than 20 millimeters. If the TTTG distance is greater than 20 millimeters, there's a 50% or greater risk of dislocation. Normal is 12 millimeters. So all our operations when we move the bone around is to try to reduce that TTTG distance down from greater than 20 to about 12. So when we're trying to decide which operations to use, there's 2 basic classes. There's the soft tissue operations and there are the bony operations. Among the soft tissue operations is the isolated lateral retinacular release. Well, the current literature does not support a lateral retinacular release for patella instability. An isolated release will reduce the lateral stability up to 20% and has the potential for iatrogenic medial instability. Lateral retinacular releases do not do well long term, and the results deteriorate with time, and they're substantially inferior to other procedures. But there are some times when a lateral release is appropriate. You would do it after you did an MPFL, medial patellofemoral ligament reconstruction, or a medial capsular reefing. You need to make sure that you have to understand that it's not needed in all instability operations. So the soft tissue procedures are called proximal stabilizations, and the bony procedures are called distal stabilizations. My indications for doing a kneecap stabilization is the patient has to have 3 dislocations. I say 3 strikes and you get operated on, kind of like baseball. The first dislocation, we treat them with therapy. Second dislocation, we reassure them and continue with therapy. But after the 3rd dislocation, we need to stop that to avoid damage to the articular cartilage. If you have an open growth plate, that's another indication for proximal stabilization because you don't want to move the growth plate around on the tibial tubercle. Now, the contraindication for a proximal stabilization would be medial facet chondral damage. This is not an operation for pain. It's an operation for instability. Medial plication is my preferred way of doing it. You can use sutures. I use radiofrequency. It's just simpler. Arthroscopic techniques were described by Ron Yamamoto first in 1986. Jeff Halbrecht has popularized that with suture stitching so that you get the medial retinaculum closed. I've used the radio frequency probe to create a series of strips with intervening normal tissue between them to allow contracture of the medial retinaculum. 53 patients were reported in 2006, 91% success rate, which is equivalent to the suture techniques. The MPFL reconstruction is gaining increasing interest of late. It is a major stabilizer to the medial side of the knee. It's the primary restraint, contributes about 60% of the total force to resist lateral translation of the patella. And reconstructions can be done with autografts or with allografts, and there's a variety of different technical reasons how to do it. MPFL is not indicated for primary dislocation. Like I said, a primary dislocation needs to be treated non-operatively. And in a level 1 study that randomized surgery with MPL reconstruction to non-operative surgery, there was no difference in the redislocation rate or any of the objective outcome scores. The indications for an MPFL reconstruction are recurrent instability with poor medial tissues, and as the trochlear dysplasia increases, the need for the MPFL graft increases. So as the crossing sign indicative of trochlear dysplasia migrates more and more distally on your lateral radiograph, then the consideration for an MPFL reconstruction becomes more significant. MPFL reconstruction is not indicated to pull the knee into the trochlea. And if you have significant articular cartilage damage on the medial side of the knee, you don't want to do one. Now, in conjunction with the soft tissue procedures, I like to have in my armamentarium some bony procedures. And there are basically 3 bony procedures in general that are out there. There's the Elmsley Trellat, which medializes the tibial tubercle. There's the Fulkerson, which anterior medializes the tibial tubercle. And then there's the trochleoplasty, in which you deepen the flat trochlea. That is more popular in Europe. The Lyon School, which is characterized by Dr. David Dejour, who is here, feels that patella alta and trochlear dysplasia are the problems that need to be addressed with patella instability. So when you move your tuberosity distally to deal with the patella alta, you also combine that with a trochleoplasty to deepen the groove. The U.S. school has different approaches. A tibial tubercle osteotomy with medialization and sometimes distalization, MPFL repair, and MPFL repair with the tibial tubercle osteotomy. Now, there are 2 different types of tibial tubercle osteotomies. There's the pure medialization, which is the Elmsley Trellat, and then there's the anterior medialization, which is the Fulkerson. But remember, the Fulkerson was initially described in 1983 as a treatment for arthritis, for chondral damage, and not for patella instability. It has lately been used for patella instability and is probably more commonly done in the United States than the Elmsley Trellat. But either one of these have the principal goal of trying to decrease this TT-TG difference. You need to have the good cartilage, and you need to normalize that TT-TG. Now, there's a biomechanical analyses that have been carried out to compare the Elmsley Trellat and the Fulkerson osteotomy. And they have found that flat or oblique cuts make no difference. And they both give equal amounts of correction for abnormal tracking and equal contact pressures. And while anterior medialization reduces the overall lateral contact pressure, there is a greater risk clinically of fracture. And the rehabilitation after anterior medialization is significantly slower than it is with just the Elmsley Trellat. Elmsley Trellat results have been good. They've been published for a long time. Jay Cox has a 26-year follow-up with only 7% recurrent instability over a quarter of a century. That's an excellent track record. And this is a picture of the operation. It's a very small incision, 1 screw, the distal tibia is moved, tibial tubercle is moved medially about 1 centimeter and fixed. You can be walking immediately after surgery. You can be weight-bearing. You don't have to be on crutches for a prolonged period of time, and you can return to sports much quicker with an Elmsley Trelot than you can with a Fulkerson. This is an example of the difference between the osteotomies. On the right is the Elmsley Trelot, which is a horizontal cut, and it's displaced on a periosteal hinge, and the Fulkerson is an oblique cut, which elevates and moves it. That requires two screws for fixation and a much slower rehab, as I mentioned. The contraindications for Fulkerson are a articular cartilage damage at the proximal pole, a TTDG within the normal limits, and pain not directly related to biomechanical abnormalities. It is important to remember with any of these, you do not want to pull the patella onto damaged cartilage. The Fulkerson osteotomy is technically challenging. There's more anteriorization. It is a much larger oblique osteotomy with a larger scar, and it weakens the tibia. There are reports of fracture of the tibia after this. It requires a stabilization, and there's non-weight bearing for 6 to 8 weeks and delayed return to sports for at least 6 months. So my treatment algorithm, with a first-time dislocation, I treat the patient with physical therapy, anti-inflammatories, and time. I mentioned to my patients it takes 4 to 6 months to come back from a patella instability, injury, or surgery. And I keep doing this, 4 to 6 months. And after I do this several times, when they come back to the office in about 2 or 3 months and they're saying, you know, I'm just not getting better. Do you remember when I said 4 to 6 months? And they say, oh, yeah, okay. So you set up the expectations at the beginning, and I work closely with my physical therapist to make sure they're working on their quad strength, working on their range of motion, and reinforcing that after patella, it takes 4 to 6 months to come back to full activity. Recurrent dislocations with open growth plates, I treat them with a soft tissue procedure. And if they have closed growth plates, then I consider a tibial tubercle transplantation procedure, such as the Elmsley Trelot. If there's lateral chondromalacia, I'll use a Fulkerson. And if they're failed, I may add a MPFL reconstruction. So in summary, proximal stabilizations are operations for traumatic instability. Distal stabilizations are procedures for pain, chondromalacia, and instability, with the bony or tubercle malalignment as the primary inciting factor. Thank you for your attention.